Hi, everybody. Good morning. Here in Taiwan time, it's good morning. I know in US, maybe now it's good afternoon, maybe good evening. Anyways, everybody have a nice weekend. Professor Mark and Professor Jenny and Professor Kinney and everybody here and our honor fellow Min Chao Huang, Professor, our Secretary General, Jian Pei Huang. Everybody, good morning. And I'm so honored on behalf of TAOC to speak some words because this is the 5th annual Congress of AD Joint Conference. And just like last year, we have many wonderful, excellent speakers like President Izet, Professor Blanchard, and the others. So we are so glad. And also we have a very excellent moderator here today, this morning. And thanks everybody for gathering together here in Taiwan and America. There seems no distance between us. Yes, we are so close. Yeah, very good. And on this late April, me and Professor Su Chongxian and Secretary General Jian Pei Huang and our Vice President Ji Changzhang, yeah, we before the ASCM meeting, we went to New Haven to see our honorary fellow Dr. Mark DeFrancisco. And we are so thankful for Dr. Mark's long-standing friendship and unwavering support for Taiwan. Yeah, it is very deeply moving. Yeah, and I know we know that he has just a little mild health challenges, but he is still thoughtfully arranged a visit to Yale University and welcome us to the home. Yeah, he has shared with his wife Helen for 36 years, where we enjoy refreshments and meaningful conversation that create unforgettable memories. And also, during the meeting, our honorary fellow Professor Jean Connery personally guided us through ACOG headquarters and its library museum. Yeah, she served as ACOG president 2013 to 2014. Yeah, and the FICO president 2021 to 2023. And her generous support and care for our society has been extraordinary, affectionately calling herself a big sister. Yeah, so she reminded us of the importance of bringing ACOG practical achievement and institutional strength back to Taiwan for the benefits of our society and the members. We are here we have so much gratitude for their support. And this morning, and we have very good academic programs and we have knowledge exchange. Yes, it's very beneficial for our members, our colleagues. Again, thanks for all the speakers and all the mentors this morning here. Yeah, we do think there is no distance between Taiwan and America. Yeah, and we have some words from Dr. Mark. Yes, and please, video or video? Okay, please.
President Wei Chun-Cheng, Secretary General Jian Pei Huang, members of the TAOC board, esteemed faculty and attendees. For the 5th straight year, I have the honor and pleasure of introducing the Joint AT Virtual Conference. Please forgive my appearance. I've made a decision to try to grow a beard, so I look a little fuzzier than usual. I apologize. As you will see, we have a most interesting collection of excellent speakers and moderators. I'm sorry that I am unable to be with you in person or even in real time this year, and I do want to congratulate TAOC for hosting another very successful meeting. I look forward to more meetings in the future as we continue our collaboration, and again, I want to say a special thanks to all of my friends in Taiwan. I miss you very much. Thank you.
Thanks, Mark. We are missing you very much too. Yeah, maybe we are. There were many chances for us to meet again. Yeah, thank you. And now I will. We are move on to the first talks. Yes. So please, the moderator, Professor Minzhao Huang, and Professor Jenny Connery. Yeah, the first talks, please. Thank you.
Okay, thank you, President Wei Junzhang. Mark, you can say something. Okay. Okay, good. Mark, miss you. Okay. Mark is the fifth the AT Joint Conference. 5 years ago, we and Mark start this AT Joint Conference during COVID-19 pandemic. Yeah, after the 5 years conference, I think the bond between the ACOG and TLG gets stronger. So it's very important to our society. I think we can go together and cooperation in the health and healthcare of the woman in the future. Okay. Today is my great honor to co-chair with Jenny for the first talk from the Mayshare Blanchard. Jenny is well known by the TLG members. He is the former president of the ACOG and also the former president of the FIGO. She was also the honorary fellow of the TLG. Come to Taiwan, visit very times. Yes. Okay. So Jenny, would you please introduce the Mayshare Blanchard first? Okay, the president-elect of the ACOG. Would you please?
Absolutely delighted to. I am delighted to share this introduction to this TAOG ACOG program with my dear friend and colleague, Professor Ming-Chao Wang. Congratulations, Professors Wei Chun-Cheng and DeFrancesco, for developing today's great program. It's my great honor to be an honorary fellow and be your big sister. Our first speaker is the ACOG incoming president, Professor Mayshare Blanchard, who is the professor of obstetrics and gynecology and reproductive sciences, University of Maryland School of Medicine, the vice chair in the Department of Obstetrics, Gynecology and Reproductive Science. She is the division chief of gynecology and obstetrics and Department of Surgery in their Midtown campus. And I think one of her important roles really is she's the associate director for the residency program, because I can tell how often the residents just treasure their interaction with Dr. Blanchard. This professor has excelled in leadership at every stage in professional development. We've all watched her since her first ACOG days as a junior fellow to her very, very important role as our next president. So please join me in welcoming Dr. Blanchard today as she discusses the effects of fatigue and sleep deprivation on performance in obstetrics and gynecology. Dr. Blanchard.
Thank you so much for having me. It's a real honor to be part of this program, and I'm very excited. Some fascinating talks that are upcoming as well. Good morning and hello. It's a pleasure to join you for the 5th America-Taiwan Joint Virtual Conference. I'm Dr. Mayshare Blanchard, professor of Obstetrics, Gynecology, and Reproductive Sciences at the University of Maryland School of Medicine. I'm going to speak today on the effects of fatigue and sleep deprivation on health and performance in OBGYNs. My objectives are to discuss the effects of fatigue and sleep deprivation on performance, describe intrinsic and homeostatic sleep drives, identify effective strategies for fatigue management. Here's a scenario. A resident falls asleep during a conference lecture given by the attending physician. Both the resident and the attending treat the episode as though it were impolite, a simple lapse in judgment, and not a serious symptom indicative of sleep deprivation. There are myths surrounding fatigue and sleep deprivation. 1, excessive fatigue is caused by things other than sleep deprivation, such as boring lectures, stuffy warm rooms, bad habits, or even laziness. In fact, falling asleep in lecture is only caused by sleepiness. If a resident is bored, he or she is awake and annoyed at being bored. Excessive daytime sleepiness means that the person in question is not getting enough sleep. And sleepiness can also be a sign of an underlying medical condition or disorder, such as narcolepsy or sleep apnea, and may need to be ruled out by appropriate medical evaluation. Myth number 2, sleep deprivation is not associated with health risks. On the contrary, sleep deprivation affects cognition and performance. In those who are sleep deprived, response times can be equivalent to being legally drunk. Many residents report having car accidents or near misses because of sleepiness after on-call duty. Speaking to a room full of OBGYNs, I know we're all no strangers to extended work hours and sleep deprivation and fatigue. This interesting article was published in the Taiwanese Journal of Obstetrics and Gynecology and tried to evaluate work hours of employed obstetricians in Taiwan, acknowledging that obstetricians have longer work hours. They surveyed 196 employed obstetricians who delivered at least 20 babies per month, and they had 72 respondents. The average weekly work hours for the respondents was 80 hours per week, but increased to 117 hours if time awaiting delivery was included. The average work hour of physicians without on-duty work was almost 64 hours per week, but with on-duty work went up to 92 hours per week. Is it merely fatigue that causes the negative effects of sleep deprivation? Is it just exhaustion that results in drowsy driving and focus errors at work? Partially. We have to also look at some intrinsic drives that contribute to the effects of sleep deprivation and its negative effects on function. Subsequently, we'll talk about how sleep deprivation causes impairment and some strategies toward offsetting the effects of sleep deprivation and impairment. Specifically, strategies including napping and the concepts of sleep inertia and sleep debt. Sleep in humans is regulated by two processes that combined determine the sleep-wake distribution and sleep duration. There's the circadian rhythm, which is sleep independent, and the homeostatic sleep drive, which is a sleep-dependent process. The intrinsic circadian system is a timekeeping system which modulates many physiological systems, including daily rhythms in core body temperature, cortisol, and appetite. The circadian rhythm also actively drives wakefulness during the habitual waking day, helping to offset the progressive increase in sleepiness from the sleep system, which drives sleep pressure as periods of wakefulness extend. The typical circadian rhythm is on a slightly longer than 24-hour cycle, but is adjusted based on daytime and nighttime cues from daylight and nighttime light cycles. Sleep homeostatic drive, which is this dotted line, accumulates during wakefulness and promotes the initiation of sleep. The longer one is awake, the stronger the sleep drive becomes. After the first half of the sleep episode, this sleep drive rapidly diminishes. A properly aligned circadian system increases drive for sleep at night, particularly in the latter half of the night, helping to maintain sleep consolidation until normal wake-up time. One of the biggest challenges of irregular call schedules or extended call shifts is this disruption in normal day-night systems and the sleep drive, coupled with the interference with circadian rhythms of alertness. The homeostatic drive for sleep is dependent on time since the last sleep episode. Thus, the need for sleep builds with sustained wakefulness and conversely dissipates with sleep. Circadian rhythms under usual circumstances promotes wakefulness during the daytime and sleep at night. They can oscillate independently from sleep and external schedules, but are calibrated and synchronized by environmental cues, most important of which is natural sunlight or bright artificial light. Under usual circumstances, for example, day workers, individuals go to bed when their sleep drive is high and their circadian signal for alertness is low. As an example, night shift workers often attempt sleep during the day when endogenous rhythms are promoting alertness. This effect results in fragmented and restricted sleep, leading to excessive sleepiness and associated impairment during the wake period. In addition to severely reduced sleep duration, night workers are likely to be working at times when the circadian signal for alertness is minimal, resulting in poor work performance, impaired quality of life, and significantly elevated risk for driving accidents. Most adults, on average, require approximately 7 to 8 hours of sleep every 24 hours to satisfy their physiological needs. When people get less than 5 hours of sleep over a 24-hour period, their peak mental performance usually deteriorates. In a medical setting or on a drive home, the consequences can be serious. In comparing chronic health conditions by sleep duration, reported incidence of some chronic health conditions can be as high as 60 to 70% more common among those who report inadequate sleep as compared to those who report sufficient sleep, particularly in conditions such as depression, coronary artery disease, and diabetes. Mental health is a significant driver and impact from sleep and fatigue as well. All psychiatric conditions have associated sleep disturbance, and the relationship appears to be bidirectional. Disturbed sleep can exacerbate psychiatric conditions, and psychiatric treatment can improve sleep. Sleep changes precede the onset of bipolar disorder, and obstructive sleep apnea is more common in patients with psychiatric illness. Insomnia and anxiety are closely related in many patients, and 90% of patients with post-traumatic stress disorder have insomnia. There are ACOG committee opinions addressing things such as fatigue and patient safety. And these are two of our colleagues from ACOG leadership, former and current ACOG District 9 chairs, Dr. Lori Gregg and Dr. John McHugh, who are real proponents of wellness in physicians. The key recommendation from this committee opinion identifies that with a growing concern about potential consequences of healthcare provider fatigue on patient safety, physicians should commit to evaluating the effects that fatigue has on their professional and personal lives, and should demonstrate willingness to adjust workloads, work hours, and time commitments to avoid fatigue when caring for patients. There's another committee opinion that talks about patient safety in the surgical environment and specifically identifies stress and fatigue being a contributor to unsafe conditions, or at least consideration of that. We'll talk a little bit about the sleep cycle and sleep stages. Normal sleep is made up of two distinct alternating states: rapid eye movement, or REM sleep, and non-rapid eye movement, non-REM sleep. REM sleep is associated with dreaming and generalized muscle paralysis, except eye muscles and the diaphragm. Usually people drift off to sleep in non-REM sleep, which is made up of 4 distinct states. The heart rate, respiration, and blood pressure all decline during non-REM sleep. And progression into deeper sleep moves from stages 1 and 2, which describes theta waves in the brain, and then stage 3 and 4, delta waves. Delta sleep is the deepest and most restorative sleep. Healthy sleep cycles through these 4 to 5 stages several times over the course of normal uninterrupted sleep. In this schematic, non-REM sleep is depicted by the blue bars and REM sleep by the beige bars. Over the course of an 8 to 9 hour night of sleep, you see progressive movement through the non-REM sleep stages into REM sleep, cycling several times over the course of the hours of sleep. Around 4 to 5 sleep cycles occur throughout the night, with each cycle averaging 90 to 120 minutes. So you see here is indicated one sleep cycle, and there's about 4 to 5 of those over the course of the night. 90 to 120 minutes per cycle. And you can see on this x-axis are the hours of sleep. Fatigue and impairment. Some studies of effects of sleep deprivation looked at residents who are a very easy study group to evaluate sleep deprivation. These authors found that more than 20% of all the residents reported averaging about 5 or fewer hours of sleep per night, with 66% averaging 6 or fewer hours less per night. These residents, in particular those who were sleeping less than or equal to 5 hours per night, were more likely to report serious accidents or injuries, conflict with other professional staff, use of alcohol, use of medications to stay awake, and noticeable weight change, as well as reported working in an impaired condition, making significant medical errors. Longer periods of enforced wakefulness are associated with even greater deterioration in cognitive function. After one night of no sleep, baseline cognitive performance in residents may decrease as much as 25%. After a second night of sleep is missed, baseline performance may decline as much as 40%. Another study found that nearly 60% of emergency medicine residents reported a near-miss vehicle collision, 80% of which occurred after night work. The risk increased with the number of night shifts work per month, and the study concluded that driving home after a night shift appears to be a significant occupational risk for emergency medicine residents. But I suspect among this group, we've also had such experiences as well. Therefore, sleep is not optional, but a real physiological need. Without the necessary amount, a person cannot function appropriately. Here are some more sleep myths. I don't need to sleep and can get by with very little. That only works for so long. The more I work, the better I get at what I do. This is true, but we still need adequate sleep. Coffee and sheer grit will help me overcome the need for sleep. Again, to a point. As long as I'm awake, I can work. Not necessarily so. I always know when I'm too tired to work. This, again, isn't always the case. So how much sleep is enough? The amount that allows a person to feel alert when rested and relaxed, for example, during grand rounds. The average person requires about 7 to 8 or more hours of sleep. One night with 2 hours fewer than the usual amount of sleep is sufficient to produce significant declines in waking performance. And after several nights of 5-hour sleep periods, most adults will not realize they are pathologically sleepy. It's also critical for everyone involved to recognize the signs and symptoms of fatigue, especially those that are non-specific. These include moodiness, depression, and irritability, apathy, impoverished speech, flattened affect, impaired memory, confusion, inflexible thinking, and impaired planning skills. For example, can't come up with novel solutions, unable to multitask. Furthermore, sedentary nodding off during conferences or while driving, medical errors, microsleeps, 5 to 10 seconds that cause lapses in attention and can be extremely dangerous, repeatedly checking and rechecking work, and difficulty focusing on tasks. The importance of sleep and sleep time needs to be understood by all members of the healthcare team, residents and faculty alike. Night shift work. Sometimes program and system solutions can cause as many problems as they are designed to solve. For example, night flow systems or any night duty are associated with greater risks for patient safety. Night float exposes a residents to all the risks associated with fatigue. And studies have shown that a large majority of workers, up to 95%, are unable to adjust regardless of the division of hours. I frequently say there's 24 hours in a day, and when you're working a day shift, you can work your full day, sometimes 12 hours, still come home, do some work or other activities, and go to bed. When you're working a night shift, it seems all you can do is eat, sleep, work, eat, sleep, work, eat, sleep, work. So let's talk a little bit about fatigue and impairment and some strategies for addressing them. There are some actual pharmacologic coping strategies for night shift workers. So improving wakefulness by use of caffeine used pharmacologically can be beneficial. It can enhance alertness during the night shift, but care must be taken to avoid using it in a way that would impair daytime sleep. And 75 to 100 milligrams, about the size of a small cup of coffee, administered intermittently can help alertness and can help sustain alertness. Additionally, in the U.S., the Federal Food and Drug Administration has approved some wake-promoting agents. These are modafinil and armodafinil. Varied evidence of benefit in shift workers. When we look at studies, there are side effects of headache and nausea, and some rare, significant side effects such as Stevens-Johnson syndrome. I will say personally, I have not seen that used either in the trainee or in the attending level environment. Circadian realignment strategies. So those are things such as light exposure or certain lights in call rooms, or using light blocking glasses to help with sleep during the daytime can be helpful and beneficial to help with both wakefulness and sleep strategies. Let's talk about napping. Naps for individuals who have the flexibility to schedule naps just before or during a shift. There's evidence that indicates that naps before or during the night shift may improve alertness and performance. For safety critical operations, naps can be limited to under 60 minutes in order to minimize the chances of entering deep sleep and to reduce disorientation from sleep inertia upon awakening. Naps may be planned prior to the shift or late in the shift to improve alertness and performance. So if we look back at the sleep cycle, you can see this makes sense because one sleep cycle where you are about to then go into the deepest sleep looks like it is maybe about 90 minutes. And we said 90 to 120 minutes per sleep cycle. So you want to avoid allowing to go into that very deep sleep, stage 4. So this very interesting study took a look at having a brief afternoon nap after nighttime sleep restriction. What amount of sleep napping is most recuperative? So first they limited nighttime sleep to 5 hours. And then their controls was no nap at all. Then they looked at 5-minute, 10-minute, 20-minute, 30-minute naps to see which would be most restorative. And then they did 3 hours of post-nap testing conducted in a controlled laboratory environment. And what they found was 5 minutes had no benefit. 10 minutes showed the most significant improvement, up to 155 minutes. But 20 minutes showed some improvement after 35 minutes, and then 125 minutes. Whereas 30 minutes, there ended up being some inertia, which is that kind of blunted difficulty waking up and confusion. But then there was improvement that lasted for 155 minutes. So for both of these, you take over 10 minutes, you probably don't get to that deep enough sleep that there is that impaired waking. 30 minutes, you run the risk of the inertia, but both the 10 minutes and the 30 minutes had the longest duration of a restorative benefit. Sleep inertia. I've mentioned this a little bit, but let's talk more about what that means. So longer naps may result in sleep inertia, and this is a phenomenon characterized by impaired cognition, severe disorientation, transitory hypovigilance, confusion, difficulty in fully awakening. I think some of us have experienced that on call, and that basically is you've gotten into that very deep sleep, and it really takes either an adrenaline rush or just 10, 15 minutes of time before you can fully awaken. Sleep debt is the difference between the hours of sleep a person needs and the hours of sleep a person actually gets. Sleep debt are associated with slower response times, forgetfulness, confusion, depression, lack of motivation, and decreased morale and initiative. So if you think about it as cumulative sleep deprivation, that then results in sleep debt. At a certain point, the battery needs to be recharged. And as we talked about in some of the myths of knowing when one is sleepy, awareness of being sleepy is blunted the longer one has been sleep deprived. So combating sleep debt, that cumulative sleep deprivation, naps can help manage fatigue. While pre-shift and on-the-job naps can manage fatigue, they cannot take the place of time off, which is necessary to recuperate fully from the effects of enforced wakefulness. 2 nocturnal sleep periods are usually necessary to recuperate from the effects of night shift work. So at the end of night shift work, we usually need about 2 cycles of normal sleep to recuperate. 36 to 48 hours is the ideal period of time off. So some key principles. Signs of fatigue must be taken seriously. Residents and colleagues who display signs of fatigue should be identified, evaluated, and educated on fatigue management skills. And good sleep hygiene is critical for the practice of good medicine. And I think that's something that collectively we as obstetrician gynecologists and as physicians need to acknowledge. Certainly the impact of progressive sleep deprivation and the potential risks not only to patient safety, but also physician well-being and physician health is something that cannot continue to be ignored. So this is a very interesting comparison. This left panel was from this philosopher, Olaus Cornelius Celsus, who wrote the first medical encyclopedia in the year 50 AD. And he said, live in rooms full of light, avoid heavy food, be moderate in the drinking of wine, take massage, baths, exercise, and gymnastics. Fight insomnia with gentle rocking or the sound of running water. Change surroundings and take long journeys. Strictly avoid frightening ideas. Indulge in cheerful conversation and amusements. Listen to music. And then here's a t-shirt from the year 2020 that advocates similar activities. Eat plants, keep moving, sleep well, be present, stay calm, love people. Thank you so much for your attention, and I'm very happy to answer any questions that you may have. It's a pleasure being with you, and I look forward to an opportunity to be together in person. Thank you.
Okay, thank you. Thank you, Brentra. In Taiwan, the OBGYN doctor, the sleeping is not always enough. The fatigue and the sleeping deprivation, not great impact for personal health, but also the patient safety. Yeah. So, any question from the audience? Yes, please.
Your lecture is detailed and colorful photographic. We keep Dr. engaged with this exciting topic. Taiwanese resident physicians have worked hard, not sleeping enough. So in the year-end party, they tell me they have a beautiful dream. They have to have a travel one about can help their relax to eating delicious food, can improve their mood at a high altitude. Performing the regular exercise can trace their body and benefit. After your speech, Taiwanese doctor, we are definitely like you because because you understand their hardship and the struggle. We just say that we love you. You are amazing. I have a question. I will say you are coffee and Coca-Cola, and particularly can water sleeping. So how much morning we can eat every day?
How much what can we eat every day?
Morning.
The coffee and the Coke
Oh,
to
yeah.
refresh your
So,
mind.
I mean, there are some regimens that, you can't, at a certain point, you have too much of it, you can become desensitized to it. So there are some protocols that look at having maybe a cup of coffee or a cup of caffeinated drink again, it's a little bit more medicinal than just because you enjoy drinking it, but maybe every 60 minutes, every 90 minutes to try and combat that sleepiness. But then they also advocate not continuing it until the point at the end of your shift, because then when you have to go home and sleep, you're too revved up from it.
Thank you.
Thank you.
May I ask a question? Because the workout is very important. Now we have a regulation for the workout limitation for the resident. In US, also in Taiwan, we are weekly workouts for 80 hours. But in Europe, it's 40 hours. Yeah. But we have no regulation for the attending physician. Do the US have some regulation for the attending physician to prevent the fatigue or the exhausting induce the patient safety problem?
We have not in the US come to a point where we are restricting attending physician work hours. I do suspect that is eventually going to come on the horizon, whether it is regulation from external requirements or from our workforce, because there are actually residencies and physician practices now that are unionized, as a union. So I suspect that eventually, whether it's from the focus of patient safety or from a physician well-being and willingness to work those hours, that article that I referenced from that Taiwanese association, Taiwan Journal of Obstetrics and Gynecology, another part of it was asking physicians who responded what they thought was a reasonable work hour. And 60% said 60 to 80 hours was reasonable. And then another 30% said more than 80 hours was reasonable. And there was 6% that still said something like 100 hours was reasonable. But it didn't say what the age range of those respondents were. So I suspect, as in the US, as we have our trainees who have been used to work hour restrictions, I wouldn't be surprised if we start having those discussions at the attending level.
Jenny, we have a comment?
Could I ask a question? Yeah,
Sure.
Dr. Richard, that was a great talk because it's something that really pertained to every one of us, no matter what our subspecialties might be. Have you seen, or is there any research about the impact of our smartwatches in reminding us about our sleep cycles? Has that been incorporated in any research at all? Other than making us feel guilty because it always says our sleep cycle wasn't adequate?
I have not seen any studies incorporating that technology, except for some of the studies looking at impact of either like post-sleep or resident functions, and kind of some of that technology looking at responses there. But that would be a very interesting study to take a look and see. And how do people listen to their watches? So does the technology drive what we feel, or maybe think we feel?
Thank you.
May I have a question as well?
Yes.
Did you look at, because many institutions, including academic institutions, have gone to laborist models where people are expected to work, shifts. And how has this impacted, and then again, these are attendings, and many of the generalist groups, for instance, ours at Duke, went to a similar schedule as the residents do, where they have a night person, they have a day person, and they have a laborist group, and they actually go home the next day. Have you looked at it from that perspective, how those individuals impact their sleep? I tell people all the time, quite honestly, everybody is meant to sleep during the night as opposed to sleeping through the day. And I just as an attendant myself, I was always extremely tired after being on a night shift, regardless of whether I was going to be off the next day or not. Your thoughts on that, and how would this impact our future as we go to more laborist models? How do you feel about that improving the health of our providers and our physicians and our attendants?
I think you bring up some excellent points. I mentioned that, a lot of the solutions that we come up with sometimes open new issues and new problems. So trying to, and as you say, our bodies, looking at the normal sleep and sleep wakefulness drives, it's counteractive to sleep during the day and work at night. So you can have people who, for either their own personal needs, as well as maybe their family and home life, it is convenient for them to work those kinds of shifts, but it's still then at a certain amount of time is going to require some recuperation. And looking at other shift workers that utilize a night shift structure, that also impacts. And there's only a certain amount of time, unless you were to continue it. But part of the problem is a lot of times you'll have people who work night shifts, then try and work or live a normal weekend, and then they have to readjust and reset again. And then there's also the questions of the, changing everything into these 12-hour shifts or such. The turnover, looking at things like safety and continuity of care. If the driver is all on patient safety, there's arguments where the turnover and the continuing sign-outs over and over, things get missed, things get omitted. But certainly from the sleep and the well-being standpoint, the body, I think, still drives to work during the day, sleep at night.
Thank you. The final question from Taiwan, because I noticed by your name is Mei Xue. Do you have a good connection from Taiwan?
I do. My dad is from Taiwan, and my mom grew up in Taiwan.
So we are Team Taiwan, right?
That's right.
Thank you. Excellent talk. Okay, because time is limited, we will move to another section, okay? Okay.
All right.
Thank you, Jenny.
Doctor.
Thank you, Brencha.
Thank you.
Hello. Oh, now you
Yes.
can hear me. Sorry about that. Thank you all for joining us this morning in our next topic of the conference, Substance Abuse in Pregnancy. And I have the honor this morning of introducing you all to our American moderator, Dr. Haywood Brown. Dr. Brown is a senior VP at the University of South Florida Health and Vice Dean at the Morsani College of Medicine, also at University of South Florida. He is a maternal-fetal medicine specialist and a very distinguished academic leader. He served as a professor and chairman of the Department of OBGYN at the Duke University Medical Center for 14 years. He also is past president of Society of Maternal-Fetal Medicine and served as a leader on numerous organizations, including NIH, DC Initiative for Infant Mortality, FDA Advisory Council, etc. He was the president of the American College of OBGYN in 2017 and 2018. And as the ACOG president, he focused on disparity and women's health equity, as well as redefining the postpartum period as the beginning of lifelong health. And we are very honored to have Dr. Brown moderate this session. Dr. Brown?
Well, thank you very much for allowing me to do this. It is my honor, actually, to introduce to you Dr. Erin Christine Brousseau, who's at Brown University as an associate professor of obstetrics and gynecology at the Women and Infants Institute. She is a graduate of St. Louis University School of Medicine. She had a master's in public health from Brown, and she has been on the faculty at Brown since about 2006, if I'm correct. She has many roles that she has played in ACOG, including in APCO, so she's an excellent teacher as well as a physician, and she has taken on the challenge of educating us on Two Countries, One Challenge of substance abuse in pregnancy, which we still struggle with here. And I think she has some comparative information that she would like to share with us on this topic. Her resume includes work in this area, which is certainly still a problem right here in the U.S. And so without further ado, Dr. Brousseau, would you please present your Two Countries, One Challenge substance abuse in pregnancy?
Thank you, Dr. Brown. I just want to say a quick thank you to everyone. I am very, very honored and humbled to be with this very distinguished group of people, and I will be available for questions. Hi, everyone. My name is Christine Brousseau, and I am an associate professor of obstetrics and gynecology in Providence, Rhode Island, associated with Brown University Medical School. And I was going to talk today about opioid use in pregnancy. That is one of my primary clinical interests. I have no relevant financial disclosures. And the main objectives are just to recognize the epidemiology of opioid use in pregnancy and understand the treatment options, including prenatal and postpartum care. In the US, this has actually become a big problem in many of our cities and counties. We have the prescription opioid epidemic, which we are still noting the fallout from a time when pain prescriptions were given out much more readily, that contributed significantly to this opioid epidemic. And then that has led to illicit use of opioids in our population, and this includes our pregnant population. So the best data that we have currently is this 2023 data looking at pregnant women aged 15 to 44 in the States that reported a 5% illicit drug use in the past month. And this correlated to 0.2% of using opioids in the past month. Our neonatal exposure is where we really sort of see this even more, with approximately 6 newborns diagnosed with neonatal abstinence syndrome for every 1,000 newborn hospital stays, equating to 1 baby diagnosed every 24 minutes in the United States. Fortunately, it does seem that opioid use and abuse is much more rare in Taiwan. And the data that I found from this National Health Insurance Research Database looked between 2004 to 2019 at firstborn pregnancies and had quoted a use of 5.9 substance use per 1,000 deliveries, with the most common drug use pattern being polysubstance abuse, followed by methamphetamines, and then opioids. Screening is recommended. The American College of Obstetricians and Gynecology's ACOG does recommend routine screening for substance use disorders, and stipulates that it should be applied equally to all people, regardless of age, sex, race, ethnicity, or socioeconomic status, really to take the bias out of screening. And ACOG does recommend that screening can be accomplished in validated questionnaires or conversations, and does not require routine laboratory testing, although some of our other organizations do recommend laboratory testing. The screening tools, there are many, and the one that is publicly available is this integrated 5 Ps, which can be downloaded and taken by the patient themselves as a paper and pencil test, with fairly good sensitivity and specificity. This is just a picture of that screen that we can hand out right in our exam rooms. There are quite a few barriers to seeking treatment. There is the shame and guilt of those, particularly pregnant women who are suffering with addiction. There is a very real fear of the child protective and legal system here that will be involved in the cases of any pregnancies that are exposed to illicit substances. And then we have a bit of reluctance of some providers to even care for these patients. So as a provider who primarily does this care, I get a lot of transfers from outside offices who feel that they are ill-prepared to deal with patients that are either using illicit substances or are even in treatment. Pregnancy is a great motivator for a lot of health behaviors. We've seen this with tobacco smoking and other harm reduction behaviors. And it is also a great time to encourage treatment and recovery from opioid addiction. Always recognizing that addiction is a chronic disease and does have expected relapses. But patients are often very, very motivated to have a healthy pregnancy. Even patients that have years and years of active, heavy use of substances will be interested in treatment during the pregnancy, even if they plan to return to using illicit substances after they deliver. So the treatments that we have available, I've highlighted the methadone and buprenorphine, which I know are also available in Taiwan, but highly regulated as they are here in the United States. The naltrexone, particularly the long-acting naltrexone, is being used frequently for substance use disorders, particularly the opioid use disorders, but also for alcohol use disorder, being used here commonly in the States. We are starting to get a little bit more data on that, but it is currently used very rarely and with caution in pregnancy, primarily just due to a lack of data and theoretical risks. But the women and pregnancies who have been exposed to naltrexone, we are not seeing any negative outcomes. And then there are a few places, and there was a bit of literature that really highlighted the medically supervised withdrawal. It is not recommended, has a very high rate of relapse, but there are some parts of the US that still will do this medically supervised withdrawal, which often entails a fairly long hospital stay with slowly decreasing the exposure to the substance to reduce the risk of withdrawal to mom, and then also do fetal monitoring to make sure that the fetus is tolerating the withdrawal. We do not provide this at my institution. So when I have pregnant women who are on these medications, just like other medications in pregnancy, they often do require adjustments and increases due to maternal metabolism. Many studies have shown that the pharmacotherapy dose is not associated with the NAA severity. And I do have this conversation with patients who really do feel like they don't want to go up on their medication because it might cause more of a problem for their neonate. So having this discussion with them that if we're going to use this medication, we need to use it in order to treat your withdrawal. And if we're underutilizing the medication, there is no benefit to doing that. And sometimes that can encourage patients to use the appropriate dose of medicine. I did note, so here in the States, we often, for our methadone patients, will split dose them. So they can receive their morning dose at the federal facility, and then they will get a take-home dose for that evening, even for patients who have to get daily dosing. And in what I saw, that may not be available in Taiwan. And then I also do talk to patients about tobacco use because there is data that the NAA symptoms can be worsened by tobacco use. So if we can also do anything to reduce tobacco use during pregnancy. Comorbid mental health diagnoses are very common. Mental health diagnoses and addiction and substance use are often correlated. And this just becomes a little bit more complex, particularly as a women's health provider who is, not I'm not a psychiatrist, and, I really do lean on my mental health colleagues to help make sure that we are treating both the addiction and then the other mental health conditions that may be also at play. Prenatal care, there isn't a lot of data and recommendations for exactly exactly what fetal monitoring should be done. There is fairly good agreement on fetal growth assessments to assess and ensure that there is no growth restriction. And then fetal testing with non-stress test, biophysicals, or AFI is not routinely recommended, although we do recommend and perform that here at my institution. Just like with other medications, the opioids do. There is some evidence that breathing movements might be decreased with buprenorphine and likely with the methadone. So just knowing that if you are ordering biophysicals, that can be a finding that just might result in more testing. Intrapartum care can be a bit complex. These patients need to continue their medication if they are on methadone or buprenorphine. And then we also anticipate the need for additional pain medication because their routine dose of medication is not going to be sufficient for pain due to either vaginal lacerations or C-section. And this becomes really a touchy point because not only are providers reluctant to be administering opioid pain medication to somebody who has struggled with opioid addiction, even patients themselves often really try to avoid these medications. So, really trying to be proactive with our intrathecal medications if they do have a C-section or have an epidural. We can often get them about 24 hours of pain relief with an intrathecal injection, and really being mindful about being proactive with ibuprofen and Toradol and some of our other Tylenol medications to try to keep the pain under control. But patients who are having breakthrough pain should be given additional pain medication. And we actually stopped using any of these partial antagonist pain medications, such as butorphanol, nalbuphine, because there was we were finding so many patients who were not disclosing some of these disorders, and we were precipitating withdrawal with these medications. So we actually don't have them in use in our labor and delivery anymore. So thinking about the fetal and neonatal effects, I work very closely with our pediatric colleagues here in patients that I am treating for this disorder, and arrange meetings with the pediatric team at our hospital prior to delivery so that they can meet mom and the family and go over the type of care that they anticipate to be providing to the neonate. We have this neonatal abstinence syndrome, which is a bit more vague, versus the NOWS, which is opioid specific. And there's quite a bit of overlap with both of those diagnoses. But for my patients who meet with the pediatric team and get to understand what types of things the pediatric team is going to be looking for, the babies stay in the hospital longer. The average day for those even without symptoms on the buprenorphine is about 5 days, and with my patients on methadone, the pediatric team wants the infant to stay in-house in the hospital for at least 7 days. And I find that this is all a lot better received if the patients and family know all of this ahead of time. We do encourage breastfeeding as long as there are no other contraindications. And I talk to my patients about this decreasing the severity of NAS, decreasing the need for pharmacotherapy, and can decrease infant hospital stay likely due to reducing the two other factors above. Postpartum care, just as we may have increased the medication dose during pregnancy, now that they're postpartum, we may need to decrease it. And so, really working closely with these patients and looking for signs of oversedation and overmedication. There is a unfortunate quite high rate of return to substances within the 6 months postpartum. So I try to keep in close contact with my patients, monitoring closely for postpartum depression. Try to utilize, like we do with all of our patients, discussing postpartum contraceptive plans to avoid any unintended, undesired pregnancies during this period. And really try to be very supportive to these patients. Oftentimes, there is a lot of child protective services and legal issues that they are dealing with, depending on what other issues may be happening in their lives. They may be separated from the infant with need for court visits and other custody issues. So these things can really really be hard on patients who are struggling to stay in recovery. In the US, and particularly in Rhode Island, where I know the data the best, the number one reason for postpartum maternal death is substance use disorder and overdose. So that's just a little bit of an overview of one of the clinical scenarios that I personally deal with quite a bit here in Rhode Island that I just wanted to share. I do think from what I've read that it is a much bigger problem for us here than for you all, and I hope that is true. But I want to thank you for this invitation. And be available for any questions or comments.
Thank you, Dr. Brousseau, for the wonderful presentation. Do any in the audience, either right here, have any questions for Dr. Brousseau? I actually have a question. Opioid crisis is not as big in Taiwan, but it is growing in numbers. And I think in Taiwan, one of the big problems we're facing is actually use of stimulants in pregnancy, like methamphetamines. And also, like, if you follow Taiwanese news for the last 2 weeks, young people these days, they vape using etomidate, which is a stimulant. And we, as OBGYN, is difficult for us to figure out how best to treat the patient in Taiwan because of the cultural background and policy constraints. When we see patients with stimulant use, I think the current rationale is patients get referred to OBGYN, and we also refer them to social services and psychiatric services. And so on. But what would be your suggestion for patients, mainly targeting polysubstance abuse and stimulant use?
Yes, unfortunately, I took the easy way out with the opioids where we actually have treatment. We in Rhode Island really, or the Northeast in general, the methamphetamines and the amphetamine use and stimulant use really is sort of creeping in within the last year or two. We went many, many years without seeing this, where, you know, our colleagues in other parts of this country and certainly in the world are definitely seeing that more frequently. And, you know, I share the frustration that there really is not, to my knowledge, a great treatment. And, you know, so cognitive behavioral therapy and working with my psychiatric colleagues. But I find that it is very, very difficult, and I have not had any success, you know, with any sort of, you know, treatments in, you know, addressing the amphetamines. And I agree. I think that is becoming a very huge issue, and hopefully, you know, there will be research and to help address that. But to my knowledge, right now, it is very, very tough.
I have a question for you, Dr. Brousseau. And one of the things you mentioned, of course, is that this is a leading cause. Opiate overdose in particular is a leading cause for maternal death postpartum. You know, my whole focus has been on postpartum care. Can I ask you about the type of community engagement that you use when your patients are discharged from the hospital for their follow-up, and particularly how you connect them with the centers that they need to be engaged with in order to be able to maintain their sobriety from backsliding to the use of opiates?
Yeah, it's a great question. A lot of times throughout their pregnancy, I have already started to work within those communities. We have community health workers. So, I mean, that's the optimal case is that I have had prenatal care and I have already worked with the community health workers, and the patients and the families are already um, hooked in with somebody who can continue to check on them. Um, I make appointments frequent. I'm sure from a billing standpoint, they are not very happy with me, but I frequently check in. I have 4 and 5 postpartum appointments with them before 6 weeks. Really just trying to be that support. But I will say that one of the worst things that happens to me is a child protective service involvement where the child has been taken and then I lose that patient. They are no longer engaged. They really, I often don't get them coming back to my appointments at all. And I will say the hospital hired a peer support who is a previous patient who has struggled, who had child protective services involved. And that made a huge difference to a lot of my patients who actually said, you know, this is somebody that I can relate to and I can trust. And she actually will go out in the community to homes, you know, and try to re-engage people who disengage. But I agree with you. I have a very big focus on postpartum. I think, you know, for a while it just sort of seemed like the babies were born and then we just kind of were done. And that is absolutely not true. And I do try to use those things to continue engagement.
My other question for you and for our Taiwanese colleagues is how do you prescribe a normal amount of opiate for cesarean patients? And when they go home, how do you tailor that so that they do not use it prolonged and potentially get addicted?
Yeah, well, it was actually kind of done for us a little bit here in Rhode Island. So we have very strict law. So 3 days, that is, you know, you can get 3 days worth at discharge from both C-section and other surgeries. So having that conversation way up front to prepare patients. In the rare case where somebody does need a couple additional days, they can come in and I do see them in person. But it's been a little bit of time and the community has sort of just understood that our hands are very tied. So it actually made things a little bit easier for us to actually have regulation so that, you know, patients just know this is how much you're getting. And then really, you know, trying to focus on, you know, other ways to manage their pain.
In answer to your question, Dr. Brown, in Taiwan, as Dr. Bosso spoke earlier, the substance abuse rate in pregnancy that we know of, published last year, was about 0.6% of deliveries, but the number is increasing. And I think here in Taiwan, with policy constraints and cultural norms, the way we do the medicine here is when we do have patients with substance abuse problems, we usually co-manage with our psychiatry consultants, specialists, to manage the medication for well inpatient and also postpartum. And these patients are usually referred with social services help to our local Department of Health, who then take over the, I guess, team management care for these patients and their babies. So usually the Department of Health doctors are major players in the care of the patients who have substance abuse in pregnancy and the postpartum care. But a lot of work can be done, like Dr. Brown said, in terms of peer engagement and community engagement is something that Taiwan can definitely do a lot with to help the patients so they don't feel that they are by themselves. Do anybody else have a question in the audience? If not, thank you very much, Dr. Prasad. Thank you very much, Dr. Brown.
Good morning, everyone, either in person or online for this symposium. I'm Dr. Hang from Taiwan. Currently, I'm the president of Taiwan Urogynecology Association, the TUGA. And it's my honor to co-chair this section with Professor Ted Anderson in the US. May I introduce Professor Anderson at first. Ted got his medical degree from the Vanderbilt University School of Medicine, Nashville, Tennessee, in 1993. And Ted is currently the Vice Chair of Faculty Development of the Betty and Lonnie Espinel Professor of Obstetrics and Gynecology. And he is also the past president of ACOG from 2019 to 2020. So would you please, Ted, introduce the speaker of this section for us? Thank you.
Sorry, I forgot to unmute. Thank you very much for that kind introduction. I am honored to be on the stage with you to co-chair this session and to participate in this wonderful international conference. I want to introduce you tonight to Dr. Kristen Hung, who is an attending urogynecologist at Mass General Hospital Brigham program. She has a long and storied career. After finishing her undergraduate degree at Harvard, she went to medical school at University of Michigan, and then subsequently completed her residency training at Beth Israel Deaconess Medical Center in Boston, and then stayed in Boston at Mass General to complete her urogynecology fellowship, and now is a practicing urogynecologist in the Harvard system and an instructor at OBGYN and reproductive sciences at Harvard Medical School. But she's also director of quality and clinical operations in the Division of Urogynecology and Reconstructive Pelvic Surgery at Mass General Hospital. Tonight, she's going to talk with us about some practical approaches to common genitourinary symptoms, which we all need. Those of us who don't practice urogynecology are always looking to people like you to give us some practical tips so that we can triage those people and send them to the right place. So I'm very excited to hear your talk tonight.
Thank you so much, Dr. Anderson. It's feels really special for me to be here because 虽然我在美国出生的，我的家人拢是台湾人, so I feel very, it's an honor to be here with you all today at this conference. Hopefully it's a helpful topic. Good morning. Thank you for having me. It's an honor to be here with colleagues across the ocean. My name is Kristen Hung, and I am a urogynecologist at Massachusetts General Hospital and on faculty at Harvard Medical School. My clinical focus is on these exact conditions that we will be discussing today: urinary tract infections, pelvic floor disorders, genitourinary health across the lifespan. As OBGYNs, we are on the front lines of women's genitourinary health, and so I hope today's topics will be helpful to you with your patients. I have no relevant financial disclosures to share. So I hope you will leave with 3 things from my presentation. First, a real appreciation for how much these conditions overlap and why that overlap is a source of so much diagnostic confusion. Secondly, a practical framework you can apply immediately in your clinic to distinguish between a UTI, genitourinary syndrome of menopause, which we call GSM, and overactive bladder, or OAB. And third, a clear sense of when to treat yourself and when to refer. I want to start with a patient. She comes to your clinic and says, I have urgency and burning when I urinate. It gets better with antibiotics, so it must be a UTI. May I have more antibiotics? I suspect many of you have heard some version of this request. So what do you say? You say, it depends, and that is an honest, correct answer. The reason it depends is here. The same symptoms, urgency, burning, frequency, can come from 3 completely different conditions: a true UTI, genitourinary syndrome of menopause, or overactive bladder. And here's a critical point. If this patient actually has GSM or OAB and we keep giving her antibiotics, we are not helping her. We're exposing her to side effects, contributing to antibiotic resistance, and missing the real diagnosis. So she'll keep coming back. And that's why we're here to talk about how to stop that cycle. So here I've really kind of tried to drill home the point of why this is so hard. These are the 3 conditions and all the symptoms that present with these conditions. So on the left, you have symptoms of a UTI, in the middle GSM, and on the right OAB. Every single symptom on this list appears in all 3 conditions, and that's a fundamental problem. The implication is simple but important. You cannot diagnose any of these based on symptoms alone, because there's no way to tell. Symptoms tell you something's wrong, but they don't tell you what is wrong, so we need more information. So before we get to the diagnosis, let's appreciate how common these conditions are, because the context does matter. UTI incidence rises within the lifetime, but even across the population, it rose between 1990 and 2019 by 66%. Roughly half of all women will have at least one in their lifetime. GSM is similar, 50% are affected in menopause, but very few will actually seek or receive treatment. This is one of the most underrated conditions in women's health. Many women think it's just an inevitable part of aging that they have to deal with and live with, but actually it's treatable. Overactive bladder affects 30% of women over 40, and it's the number 2 reason for referral to a urogynecologist. It has a huge impact on quality of life, sleep, work, financially. People take a big hit when they are homebound or they have to buy diapers. They're at risk for falling down on the way to the bathroom at night, especially if they're older. None of these conditions are rare, and they're frequently mistaken for each other. So now let's talk about urine testing, because that is where we should start. What can a urine test tell you and what can it not tell you? Because there's a lot of confusion even amongst people who order these tests every day. There's 3 main levels or types of urine testing. The urine dipstick is at the point of care. You get the results within minutes or seconds, and it tells you whether there are chemical factors that indicate whether more testing is indicated. This is very convenient, but also very non-specific. It can be positive and not actually be a true infection. Urinalysis or microscopy, usually you can get it by the end of the day or the next day, but this needs to go to a formal lab, and it gives you everything on the dip plus an actual microscopy count of white blood cells or red blood cells per high power field, which is much more informative and much more specific. The urine culture takes a few days, and it's the only test that tells you about whether there's actually an organism or pathogen present. And the lab usually will also tell you what antibiotic is most appropriate for that organism. The most important thing to take home from this slide is that a urine dipstick that we do at point of care in the office is not enough to diagnose a UTI. So that's the key teaching point. Urine dip is not a diagnostic test, it's a screening test. It's the most important point about UTI learning today. A positive dip is not a UTI, but a negative dip doesn't always rule out a UTI, but it is pretty specific that if the dip is totally negative, it almost never is a true UTI. A positive dip with no cultures is still not enough to prescribe antibiotic, and other things can cause a positive dipstick that are not related to infections. So, some things to point out. If you have pyuria but no pathogen, meaning there is white blood cells on the microscopy but the urine culture grows out with no isolated pathogen, then it could be a stone, it could be an STD, but it's not a true UTI. If you have a pathogen that grows out but the urine microscopy is totally normal, you have what we call colonization or asymptomatic bacteriuria. This is also not a UTI and should not be treated. Even if you see E. coli growing out, but the patient has no symptoms or there's no white blood cells on microscopy, those patients should in fact not get antibiotics. Instead, we should be thinking about conditions like GSM or OAB. The other thing is that if you do see microscopic hematuria, RBCs, red blood cells on a microscopy, that should always be referred to a subspecialist. Hematuria of any kind should always be evaluated, but it is not necessarily an automatic UTI when you see just hematuria. So coming back to this overlap table, I want to emphasize it again that all of these symptoms can mimic each other. And because antibiotic resistance is a growing global crisis, if we keep over-treating patients with antibiotics and over-diagnosing UTI, missing GSM and OAB, we're doing patients a huge disservice and just contributing to the growing army of drug-resistant pathogens out there. So proper diagnosis is essential. So to reiterate, the requirements for UTI diagnosis: all three criteria must be met. You must have symptoms, you must have pyuria, meaning white blood cells on a urine or a urine sediment, and you must have an isolated pathogen, so not mixed bacteria, not commensal flora, but an isolated pathogen that grows out. All of these three are required for a true diagnosis of UTI. In terms of treatment, the first-line treatment aligning with international guidelines is nitrofurantoin. It's the best option with high urinary tract penetration, broad coverage for E. coli, and has minimal resistance impact. Trimethoprim sulfamethoxazole is a second choice, less favorable because in some regions resistance is actually growing to it. Fosfomycin is a good one-time dose that's convenient for patients, especially those who have a lot of allergies to other drugs, or if the data is not available. What to avoid is fluoroquinolone. So ciprofloxacin, levofloxacin have historically been the most widely used antibiotics for UTIs and now have built a lot of resistance. And so these should be saved for complicated or ascending infections. To decrease the rates of UTIs, we need to first understand how the vagina and the urinary tract are connected. They share a microbial ecosystem. So E. coli, which is the most common uropathogen, actually lives in the gut and uses the vagina as a reservoir. With decreased estrogen levels, the bacteria in postmenopausal women changes, and lactobacillus is less able to suppress other pathogens like E. coli. That's why vaginal estrogen, not oral or systemic estrogen, helps with recurrent UTI rates. It shifts the microbiome back toward lactobacillus dominant low pH environments that is then hostile to uropathogens and suppresses them. This is the biological foundation for what we're going to discuss about vaginal estrogen. So here's the mechanism. Estrogen drives glycogen production in vaginal epithelial cells. The lactobacillus metabolizes that into lactic acid, which lowers the vaginal pH, making it inhospitable or inhibiting uropathogens. The lactobacillus also itself physically prevents uropathogens from adhering to the epithelium. So when estrogen levels fall in menopause, in lactation, and other medications, this entire cascade breaks down, glycogen drops, so lactobacillus disappears, the pH rises, and pathogens from the rectum now colonize the vulnerable vaginal tissues, and that's why recurrent UTIs spike. For postmenopausal women, it's also why vaginal estrogen works. A meta-analysis of randomized controlled trials showed that vaginal estrogen reduces the relative risk of UTI by more than half, 58% reduction. So this is one of the strongest effect sizes we have in UTI prevention. This is a simple diagnostic tree that is helpful to illustrate your thought process as you evaluate patients. We'll come back to it at the end when it'll make a lot more sense. But when you have a patient who presents with genitourinary symptoms, the first step is to rule out a UTI and to properly diagnose a UTI if it's there. And so that's this branch down here. And then we'll come back to the other two branches later. So first, let's talk about GSM, because this is where we have the biggest opportunity, I think, to improve care. Genitourinary syndrome of menopause. We used to call this vulvovaginal atrophy or vaginal atrophy. The terminology changed a while ago to be more accurate and demonstrate the full scope of what is affected. The causes: declining estrogen, and because estrogen receptors are present throughout the genitourinary tract, these effects are pretty widespread. You have dryness, itching, burning, irritation, painful intercourse, and that's the vaginal symptoms. People complain of bladder urgency, dysuria, recurrent UTIs, urgent incontinence. And so you'll notice that the bladder symptoms and the UTI symptoms are quite similar. And this is why GSM gets misdiagnosed as UTI over and over. So one thing that's very important to keep in mind, GSM is not just for the postmenopausal. Any low estrogen state can cause it, and that includes women in OB clinic, not just menopause clinic. Postpartum and lactating women are suppressed, and this is a common, very under-recognized condition where they are essentially in postmenopause. New mothers, they have painful intercourse, burning, dryness, and they're suffering, not realizing that they are in fact menopausal. Women on combined OCPs are similarly. They can develop these GSM symptoms. They have hormonal suppression. Hormonal IUDs and implants are similar. People who are being treated for endometriosis or fibroids with a GnRH agonist are in profound medical menopause. Women who have undergone chemotherapy for breast cancer, any type of pelvic radiation, surgical oophorectomy, these are all conditions in which they are at high risk for GSM. Athletes and women with eating disorders will have a hypothalamic amenorrhea. So any of these patients, if they come to you with burning, urgency, recurrent UTIs, consider GSM even if they're 28 years old. How to look for it, what to look for. So GSM is a clinical diagnosis. There's no blood test or biopsy to be done. You need to just examine the patient and you're looking for these changes. And what you're looking for is a loss of architecture. The labia becomes smaller, diminutive, tighter. There is a pale appearance to the epithelium. There may also be actually erythema, an appearance of irritation or bruising. There can be a lot of friability on the vulvar skin. And then also at the urethra, you'll notice a caruncle developing, or the urethral meatus becomes very tight and retracted, and you start to see the urethral lining pop through, and that's what a caruncle is. Inside the vagina, it's also very pale, it's smooth. There's a loss of rugae, which is the hallmark to look for. The tissue inside can also be very friable and can look bruised. You can see petechiae. And a lot of times the discharge is either altered or absent. If you find a pH greater than 5, that strongly supports GSM, because a healthy premenopausal vaginal pH is around 4. So this picture shows the difference between normal rugated vaginal mucosa and the atrophic, smooth, pale mucosa of GSM. So this is what it actually looks like on exam as well. So you've made the diagnosis. What do? First line is vaginal estrogen. And again, women on HRT, on systemic hormonal replacement, is not enough. They still also need to be on topical vaginal estrogen. It has the best evidence and the best safety profile, and it is the most underutilized in clinical practice. It comes in 3 forms: cream, tablet, and ring. And you can see kind of details of the brands, at least we have in the US, and the formulations there. In terms of safety, and this is where clinicians and patients both often have misconceptions and then miss out on important treatment because of safety concerns. The important thing to know is that it's very safe and effective. Vaginal estrogen has minimal systemic absorption. It's not the same as oral or patch hormonal therapy. Serum levels using vaginal estrogen are low or negligible. It is even safe, according to the Society of Gynecologic Oncology, it's safe in early estrogen-driven cancers. It's also safe in estrogen-positive breast cancers, even with patients who are on tamoxifen or an aromatase inhibitor. The ACOG clinical consensus as well as the SGO clinical practice statements support this. One thing to know is that the labels and the inserts in our commercial vaginal estrogen products are actually just the same that was given in the high dose HRT, and so those risks are actually inaccurate, and at least the United States FDA is actively changing that now to be more accurate. In all its years of use, vaginal estrogen has not been found to cause any cases of cancer or stroke or blood clots. For patients who really cannot use other options, or who really cannot use vaginal estrogen, there are other options, but vaginal estrogen is the safest, effective, and most cost-efficient as well. So OAB is our third condition. Overactive bladder, defined by the International Continence Society, is urgency with or without urgency incontinence, usually also with frequency and nocturia, and most importantly, it's in the absence of UTI or other identifiable cause. That last phrase is essential. OAB is a diagnosis of exclusion. You cannot diagnose OAB unless you have ruled out UTI, ruled out GSM, and other structural causes. It affects 30% of women above age 40. Its incidence increases with age, and it's a huge impact on quality of life, sleep, work, fall risk. It's a big financial cost to both the patient as well as the healthcare system. So first, to make the diagnosis, like I said, you rule out UTI, GSM, and also hematuria. You don't need to go overboard with the testing, but you do need to rule these out. Taking a thorough history and having the patient do a diary is helpful. What are some triggers? When is the urgency worse? And what is their intake? Because there are certain fluid intakes that will increase one's risk for OAB, such as caffeine, alcohol, seltzer, anything with bubbles or carbonation, as well as anything with sweeteners. And so in a lot of older patients, they drink a lot of tea. It's very soothing, but this can be a big culprit. So urodynamics are not needed to make the initial diagnosis. This is something you can do in your clinics without any special equipment. Things to keep in mind that are red flags that should prompt a referral or further workup is hematuria, whether it's gross or microscopic, and recurrent UTIs that are failing the routine vaginal estrogen prevention, or people who have had prior radiation or mesh. Those are cases that warrant sooner referral. In terms of treatment, I'll walk through this in the next 2 slides, but it starts with behavioral approaches and then graduates to more intervention. So the things that are in the patient's hands are what they take in, and these things matter, as I mentioned. What we drink will greatly irritate the bladder without even knowing it. But what the patient can do is modify their fluid intake. Behavior changes, though, are hard. Bladder retraining can be done very well with the help of a pelvic floor physical therapist. Things that are in your hands are very little, actually, compared with what was in the patient's hands. You can place a PT referral, you can do counseling, but a lot of the action needs to be taken by the patient. For patients who fail first-line treatment, then we're on to medications. That's more in your hands because you can prescribe them. There are 2 main categories, 2 main classes of medications, and I have strong preference for beta-3 agonists because we now know that anticholinergics are associated with significant side effects, and most importantly, are linked to cognitive impairment, increasing the risk of Alzheimer's dementia by 50%. So this is a real proven signal in the literature that we need to take seriously now. And so in my practice, I try not to prescribe anticholinergics whenever possible. A lot of the insurance companies are not on board, and they force us to prescribe anticholinergics first, and so I will opt for trospium, which is a larger molecule. It's a quaternary amine, which means it doesn't cross the blood-brain barrier, and so we are hoping that it is not as strong of an implication for the dementia in terms of long-term use. So what I haven't mentioned about OAB treatments is about how vaginal estrogen plays a large role. So this is actually the biological bridge between GSM and OAB, because vaginal estrogen helps OAB. It decreases urgency, and this is why, as you can see, these dots represent estrogen receptors, and you can see that here in the bladder and in the trigone, there's a high density. There's a high density in the urethra, in addition to the vagina and the vulva. So it's not just vulvovaginal atrophy, it's genitourinary syndrome of menopause. And that is why, because you can see that these estrogen receptors are everywhere, and that's why treating GSM and with vaginal estrogen actually also improves OAB symptoms in many patients, because you're not just treating the vaginal canal and the vulva, you're actually restoring the entire lower urinary tract. This flow sheet summarizes the mechanism. So estrogen-dependent tissue is everywhere. Declining estrogen causes a host of symptoms, atrophy across all of the areas, and therefore, after there's urethral thinning, there's trigone sensitization, they converge back to vaginal estrogen reversing all of this. It is the most important tool possibly in our tool belt at this point with these symptoms. So let's go back to where we started. The patient says, I have urgency and burning, it gets better with antibiotics, it must be a UTI. May I have more? And so now we have a framework to answer this for the patient. The answer is probably not. So coming back to this chart to just really hone in that what I tell patients, and I use this as a script, these three conditions all have the same symptoms. The body cannot tell the difference. That's our job to tell the difference. And so now we know what to do next. We know not to prescribe antibiotics on symptoms alone. We know to send a urinalysis and how to properly diagnose a UTI. We know what to look for on an exam for a GSM, and we know how to make a diagnosis for OAB and initiate baseline treatments. So this is a picture I want you to keep in mind as the most important message of the whole talk, is that these three circles of these three conditions, UTI, GSM, OAB, all converge on vaginal estrogen. Vaginal estrogen is what reverses atrophy, reduces UTI rates by over 50%, and restores the urothelial lining in OAB. In any patient with low estrogen who presents with these symptoms of genitourinary irritation, vaginal estrogen should be considered early on. So now this is back to our algorithm from the beginning of the talk. Patients presenting with genitourinary symptoms, first is to send the urine culture. If it's positive and there's pyuria, that means it's a true UTI. Also, though, they could also have GSM and OAB, so even if you diagnose a true UTI, you want to be evaluating for GSM and OAB. If the culture is positive, however, and there's no pyuria, that's called colonization. It means no antibiotics. It means we need to look further and examine for GSM, consider OAB. If the culture is just negative, we're looking for GSM. And whether it's there or not, we're also looking for OAB and considering it depending on the symptoms. Now, if there's no GSM, or even if there is, again, you want to always consider overactive bladder because it can be subtle, and plain overactive bladder with no other issues can still look like a UTI. And so one thing to note is that if there is sterile pyuria, meaning there's no bacteria, but the urinalysis is positive for white blood cells, those are where we want to consider the less common things like an STI or a kidney stone or tuberculosis. And so further workup is warranted by a subspecialty referral. So in terms of referral, these are things that would cause you to refer to a subspecialist so that you don't have to worry alone. For a patient with UTI, if they failed basic preventive regimens, you're dealing with multi-drug resistant organisms or multiple antibiotic allergies, or if there's any hematuria, this is when you want to refer to urology or urogynecology for a cystoscopy and upper tract evaluation. For GSM, if they've been on estrogen for a few months and it's not improving, you want to consider dermatosis of some kind, or if they have dyspareunia, that could warrant a referral to a pelvic floor PT. Usually dermatology or GYN subspecialists can help you diagnose conditions like lichen sclerosus or lichen planus. For OAB, if they failed 2 medication trials, or if you notice there's retention, urinary retention, or if they've had prior pelvic surgery, especially mesh, those are good reasons to refer to a subspecialist. So to close, I want to leave you with these take-home points. 1, UTI, GSM, and OAB share overlapping symptoms. You cannot diagnose based on symptoms alone, so this is the main point of everything. Number 2, to diagnose a UTI, you need proper criteria. You need all 3 symptoms, pyuria, and a positive culture. A positive urine dip at point of care is not enough. 3, GSM goes beyond menopause and beyond vulvovaginal symptoms, so think about your young patients. Think about your postpartum patients, your patients who are on hormone suppression, or who have had prior chemotherapy. 4, avoid anticholinergics in older patients, but really in anyone. The cognitive risk is real, and beta-3 agonists are much safer. 5, estrogen is your best partner. It treats GSM, prevents recurrent UTIs, and improves OAB symptoms. It's safe, effective, and it's underutilized. And finally, referring to a subspecialist for red flag is important, and it's totally fine to do even early on. Patients with refractory symptoms, hematuria, urinary retention, prior mesh, those are also patients that are appropriate to refer even early. So thank you very much for your time. I am happy to take any questions.
Thank you, Christine, for your very clear and comprehensive talk. And it's also very happy to know we have the same last name. That's Hung, H-U-N-G.
Yeah.
I want to ask any question or comment from the floor. Actually, I have the first question for you. For the common 3 urogenital condition, as you talk about the UTI, GSM, and OAB. As I know, there is one disease called interstitial cystitis. They may have some overlap and interplay with this situation. Could you talk about the current situation in the US? How about the diagnosis and the treatment of IC?
Thank you for bringing it up. I actually had to choose to leave that out of the talk because the scope is just so broad. We call interstitial cystitis now painful bladder syndrome. It is more of a descriptive diagnosis. And again, it's also like OAB, it's a diagnosis of exclusion. It can very much complicate the picture because patients who have painful bladder syndrome almost always have all of the other 3 as well. They often struggle with recurrent UTIs because we believe, we don't know everything, but we believe painful bladder syndrome or IC is somewhat immune mediated. There may be an autoimmune component, It may be triggered by UTIs or other inflammatory or autoimmune disorders. And the sort of symptom presentation of IC or painful bladder syndrome very much is also urgency, frequency. There's a lot more pain associated, but that's where it can be very confusing to separate the diagnosis with UTI. And many of these patients are actually also colonized. And so they end up being treated and overtreated with antibiotics, which in fact just worsens the situation.
Okay, so I had a similar question I have a lot of my patients have endometriosis, and so they have this generalized inflammatory syndrome, which then precipitates IC or painful bladder syndrome. So a lot of times having these patients on anti-inflammatory medications can alleviate some of the symptoms that they interpret as a UTI as well. So do you use that often in your practice?
So in terms of sort of systemic anti-inflammatories, not necessarily, but we are actually trying to see if there are any sort of local installations. Oftentimes, regular bladder installations locally can help these patients with painful bladder syndrome. However, most randomized studies show that adding steroids to that cocktail of bladder installations actually does not have any improvement. And so that's kind of plus minus, but usually the cocktail involves heparin, which is what heals those ulcerations and regenerates the mucosal lining, as well as just numbing, Marcaine, lidocaine, and bicarb, sodium bicarb, which is really just there to neutralize the acidity of the lidocaine.
Thank you.
Actually, in Taiwan, our IC patients, about 30% of them, they may also have a recurrent UTI. So I think the antibiotics is not a definite contraindication. These patients, it also needs the personal and the precision medical treatment as well.
May I?
I have a questions. Yeah. Professor Hong, thanks for your excellent talks. I'm oncologist, and many times there are some kind of patient, just like patient with atrophic endometritis, atrophic vaginitis, and GSM. But my question is, the patient with a comorbidity with breast cancer. So you said that estrogen is the partner when we treat these kind of patients, but they sometimes have comorbidity. And we know there's commercially available E3 VT, E3 vagina tablet that maybe has less side effect, especially about breast. And what's your suggestion of this kind of medication? Because it is available here in Taiwan. I don't know whether it is available in US, and I need your comment. Thank you.
Thank you for the excellent question. So the Society of Gynecologic Oncology in the US, as well as ACOG, have practice statements stating the kind of reaffirming the safety profile of using localized vaginal estrogen in patients both with early GYN cancers as well as estrogen positive breast cancers. Now, patients who have active cancer I believe should not be treated with vaginal estrogen even, but if they are in remission, they've been treated and are with no evidence of disease, then the societies do support the use of vaginal estrogen. The systemic levels are negligible, if at all. And what I generally, in my practice, I will still defer to the oncologist. I always say, it is safe, but check with your oncologist. There are patients who just aren't comfortable with it, and I think that's extremely understandable. The question you have about formulation of vaginal estrogen. So there's actually not really good consensus from the experts. And by experts, I include my oncology colleagues. And so what happens is that some oncologists will say, well, the vaginal tablets, you can control the dose better. And I didn't include this in my slides, but I'm happy to share it later, is Here we have a cream formulation, the tablet formulation, which is 10 microgram tablets. And then we have a ring that is a slow release ring. It's 2 milligrams, and then it slowly releases over 3 months. And so the feeling amongst oncologists is this tablet is at least, it's better control in terms of how much the patient is getting, and it's less user dependent. However, the studies on recurrent UTI prevention is that it's only really the cream and the ring that are shown to decrease the rates of UTIs. However, some is better than none. And so I think, if that's the safest form or if that's the most readily available form, I think it's still reasonable to start with that.
Okay, hello, Christine. I'm Charles from McKay Memorial Hospital. I have privilege to listen to your wonderful speech. I got a question for you regarding the treatment for OAB. You don't suggest to use anticholinergics and transfer to beta-3 antagonists, saying mirabegram. But for the hypertension patients, it may cause increase of blood pressure, particularly for those of old ages. We talk more on this. If you want to use the beta-3 antagonist to the hypertension patient, how do you judge the dose or how to use?
Yes, this is a very good point to highlight. So in the US, the doses of mirabegram are 25 and 50. In Europe, they actually, I believe, start with 50 and go up to 100. I've never given more than 50 milligrams, and I do see actually about 10% of people will have a slight increase in their systolic blood pressure. The way to approach it in the office is to first look at their trend of blood pressures, and it is only contraindicated in poorly controlled hypertensives. And so if they are well controlled on their antihypertensive medication, it is actually very safe to give it. And any increase in their systolic blood pressure that might occur is almost always within about 10 millimeters of mercury. And so it's not something that I've ever seen and typically does not cause a hypertensive crisis. But I do see, yes, there's a very real small increase in blood pressures. And so for patients who are not well controlled, I avoid this. I use it as the reason to insurance companies to submit an appeal to then prescribe vibegron, which is also a beta-3 agonist that has no association with increased blood pressures. And so this is, the vibegron is actually my preferred medication for overactive bladder. Unfortunately, it's also the one that's least likely to be covered by insurance companies right now.
Thank you.
Okay, wonderful talk and discussion. However, the time is limited. We are going to a break. And thanks for everybody. Thank you. Thank you, Ted. Thank you, Christine.
Dear friends, ladies and gentlemen, I'm Charles Su from McKay Memorial Hospital, Taipei. It's my great pleasure to share with my good friends, Professor Stephen Fleischman from America. Steve nominated my honorary fellow of ACOG this year. For this, I'm very appreciated. Please allow me to introduce Stephen. Stephen is the immediate past president of ACOG. He has been the president of ACOG from 2025 to 2026. Currently, he is the associate chief, Department of Obstetrics and Gynecology, Air New Haven Hospital, and also associate clinical professor, Yale University Department of Obstetrics and Gynecology and Reproductive Sciences. He also has been the executive board member from 2022 up to now. He got many honors, including Jewish Federation President Award in 2024, and also ACOG District 1 Mentor Award in 2020, a Business New Haven Top 40 Under 40 in 2006, and also Resident Research Award in 2000. Hello, Steve. Will you say hello to the everybody and also introduce our distinguished speaker?
Thank you, Dr. Su. Great to see you, and it was great to see you just a short time ago in D.C. and actually in my hometown of the New Haven area. It's my pleasure to introduce our speaker this evening, Dr. Paul Gelhaus, who many people in the audience might recognize the name because he might have a relative that you all know very well, one of our former past presidents, Tom Gelhaus, and also a longtime friend. Dr. Gelhaus, the current one on the call, got his undergrad from Iowa State University, his medical degree from the University of Iowa. He did his residency at Indiana University School of Medicine, did a fellowship in urologic oncology at City of Hope Medical Center in California. He has received numerous accolades, awards. He's currently the chief of urology at City of Hope Medical Center in Phoenix. He has mentored many residents and fellows and has too many publications for me to list, but we are thrilled to have him here this evening to talk to us about management of GU injury with OBGYN surgery. So without further ado, Dr. Gelhaus, welcome.
Thank you all. I believe we have a video to present.
Hello, my name is Dr. Paul Gelhaus. The title of my presentation is Management of Genital Urinary Injuries Associated with OBGYN Surgery. The goals of this presentation are to review the urology anatomy, review the evaluation diagnosis, particularly focusing on intraoperative diagnosis and treatment, as well as the role of localizing stents in the ureter. The reality is 1% of all OBGYN surgery results in a genital urinary injury. This occurs predominantly in the bladder, but also a third of the times in the ureter, and is common also to have multiple injuries in both ureters or the ureter and bladder. There's no single easy solution. So why does this occur? Tumors can distort the anatomy of both malignant tumors and benign tumors like fibroids. Additionally, radiation can alter the field, making things be in areas we don't expect. In the case is the same for prior surgery. Additionally, bleeding can occur quite easily during OBGYN procedures. And it's not surprising. The ureter runs a very dangerous course under the female reproductive organs, especially near the infundibulal pelvic ligament and the uterine artery. The ureter is so intertwined with the uterine vessels, it's easy to imagine how bleeding during hysterectomy could easily put the ureter at risk during hemostatic repairs with ligature or sutures. The reality is, you're not alone. The urologist injures the ureter too, and a lot, the most for any specialty. We tend to do it more endoscopically. The good news is, urology is actually quite simple in its basic principles. And we've been doing these injury repairs for many years, and we have a good way to hopefully go about remedying this problem. The principles include using absorbable sutures to prevent stone formation from non-absorbable sutures, watertight, tension-free anastomoses, and placing stents, catheters, drains as needed, and allowing time for the mucosa to heal to seal off any urine leaks. And tissue interposition is your friend when needed. So in regards to the bladder, it's the most commonly injured organ like mentioned previously, and thankfully it's a very forgiving organ. Given the anatomical relationship of the bladder to the vaginal canal, the cervix, and the uterus, it's not surprising that it is injured often. During vaginal hysterectomy, as the uterus is being pulled into the vaginal canal, you can imagine how close the bladder is to this area to be injured. Additionally, when you have prior hysterectomy, that healing process of the uterus can often pull the bladder and fuse it to those two planes. So when you go back in for another hysterectomy, or if you're performing an abdominal hysterectomy, it can be injured quite easily. So how do you diagnose a bladder injury? If there's concerns, you can put multiple syringes of normal saline into the bladder. Some people like to use blue to really make it obvious. And if there's not a leak, there's clearly no severe injury. If you're worried about it leaking because you can see defects in the muscle, the mucosa is herniating when it's filled, it is fine to throw some imbricating sutures and leave the catheter for a few days to allow this bladder to heal fully. And no need to irrigate this balloon catheter, given the fact that you can see it here in this open surgical approach. So how do we fix this? Principles of closing the bladder. You want to use a smaller 3-0 or 4-0 mucosal closing suture that's absorbable, something like Vicryl or a monofilament like PDS or Monocryl. And then a larger suture to help imbricate the outer layers to reinforce this closure, such as 2-0 or 3-0, Vicryl, or PDS. And when it's all done, you think you've done a good job, it's always wise to test by filling the bladder and making sure there is no more leak. Leaving a catheter for a period of time will also allow the bladder to heal more fully. And leaving drains as needed based on the circumstance and quality of closure. Tissue interpositioning is your friend. Using omentum or peritoneum, you can bring another blood supply in to help with healing. And it can also be a physical barrier to help prevent fistula formation. This is particularly important when there's concurrent rectal, vaginal, or complex bladder injuries that involve the trigonal ureters. Radiation ruins the ability for tissues to heal properly, or if the tissue's been injured by the surgery itself with cautery, etc. And in regards to follow-up after the bladder has been repaired, checking a drain creatinine prior to removal, and then performing a cystogram 5 to 14 days prior to catheter removal in situations where depends on the complexity, quality of closure, tissue quality, radiation history, and the severity of injury. Moving on to the ureteral injury. Less common, but it's more morbid and higher rates of litigation, medical legally speaking. When does this happen? Hysterectomy, colorectal surgery, pelvic procedures such as ovarian tumor removal, transabdominal urethropexies, abdominal vascular surgery. So what are some common situations? Isolation of the infundibulal pelvic ligament, uncontrolled bleeding, pathological anatomy that can include either a large mass like a broad ligament myoma, a fibroid, or an adnexal mass, or extensive adhesions from endometriosis or prior surgery. And you can see the dangerous course the ureter lies as it goes down from the kidney's location in the abdomen into the pelvis. You can see here crossing over the common iliac artery. Very nice place to find the ureter is to feel for the common iliac artery and trace it down towards the pelvis. And the ureter always crosses over there unless someone's moved it. And this is the one place where water is not under the bridge. So let's give an example. 59-year-old lady, large fibroid in her uterus, subsequently has significant bleeding. They tried to do the embolization thing, didn't work. She's demanding a surgical treatment. You go in, you do an open hysterectomy. Planes are very stuck from the prior embolization. The anatomy is distorted from this large pelvic mass. You get into bleeding, but you can ligature your way through it. But where was the ureter? What do you do in this situation? Well, when you have a difficult plane, the pelvis, and you can't find an anatomy that you're expecting, always best to go to a safe spot that has not been changed by the pathology. Going up, incising over the common iliac artery where you can either see or palpate this pulsation, and then finding the ureter as it crosses over is a very nice way to go about identifying the ureter out of the pelvis. And then be gentle to it. Don't grasp it or crush it with forceps. Vessel loops can be nice, and then dissect its way down and see if it's been injured or not. That's what the urologist would do if you call them in. If you're not quite sure and that's not a helpful move, or you're not comfortable doing that, performing cystoscopy and looking for a ureteral jet, again, giving IV methylene blue sometimes can be helpful for making it very clear what a ureteral jet can look like. This isn't always perfect. Sometimes there can be partial occlusion, and that won't really show you on the jet, or the inflammation has set in to cause complete obstruction. What the urologist would like to do is perform a bladder scope, put a wire or a catheter into the ureter, and in open surgery or laparoscopic surgery, sometimes you can see it or trace it and feel it in those locations. The gold standard is to do a retrograde pyelogram. And if the ureteral injury is unclear, it's always safe to leave a stent for a few weeks and come back and remove it. This is what a retrograde pyelogram should look like. The caliber of the ureter is typically pretty uniform, except for 3 spots where there's physiological narrowing. The UVJ, or the ureteral vesical junction, aka where it inserts into the bladder, the ureteral pelvic junction, as in the renal pelvis, and the crossing of the iliacs are all normal narrowing points. This is an abnormal pyelogram. It shows 2 different abnormalities. The first one, distally, you can see the caliber narrows quite a bit. And then just above, or more proximally, you can see a small amount of extravasation. Please note that the ureter is clearly still in continuity, because you can see contrast more proximately. Looking at a different pathological finding during a retrograde on the other side now, you can see focal narrowing without extravasation, but again, the ureter is in continuity. In this case, a suture had entrapped the ureter during pelvic bleeding during hysterectomy, and this provided an opportunity for us to go in and release the suture, place a stent, as long as the ureter looked healthy. How do we fix these ureters? Depends a little bit on the location. Thankfully, the vast majority of GU ureter injuries during OBGYN surgeries in the pelvis, in the lower portion of the ureter, so we can perform reimplantations the vast majority of time. The distal ureter has a limited blood supply, so we prefer to use the bladder's blood supply, and that's where a reimplant can make a lot of sense. The technical term is ureteroneocystotomy, and again, we want to perform watertight, tension-free, spatulated anastomoses using absorbable sutures. In the bladder, you can use a variety of sizes and types. Fluorovical is my preference, but I've certainly used 5-0 PDSs. Interrupted, running, or combination, none of it matters as long as we achieve the watertight, tension-free portion. Leaving double J stents, drains, Foleys are all helpful to help promote urine to go the right direction and heal appropriately. So how is this done? To offload the tension, to perform that tension-free anastomosis for the ureter and bladder, we actually bring the bladder up to the ureter. We pull the bladder up, and we sew it to the psoas muscle, and that way that tension is on that stitch and not on the anastomosis stitch between the ureter and the bladder. A new cystotomy site is chosen, and then the ureter is pulled into the bladder lumen, and then it is sewn shut here in an interrupted fashion. But again, running continuously is acceptable as well, as long as it's watertight. Sometimes the ureteral injuries are too high for this to be performed by in itself, or the bladder capacity or size is just not big enough. So we create a bladder advancement flap known as a Boari flap. We make a U-shaped incision starting from the posterior heading towards the dome. It allows a flap to be pulled up towards the ureter. A new cystotomy is then performed, the ureter is pulled through, and again is sewn shut. And then the bladder is closed in a Heineke-Micklux fashion. And like the psoas hitch for a regular reimplant, we also like to keep the tension free by hitching it to the psoas muscle. Follow-up after reimplantation, a JP creatinine should be performed prior to drain removal, and a cystogram is typically performed 10 to 14 days later, and the stent's usually left in for 4 to 6 weeks. The ranges on this based on complexity, the reliability of the closure, and the tissue quality. We also like to perform an ultrasound in 4 to 6 weeks to see if things are draining the way we expect. Always better to have a high index of suspicion so you catch these injuries earlier, even though they suck. It's better to identify them, fix them early. Otherwise, we get these more devastating, hard to recover from complications. For bladder, they fill up their abdomen with urine and they can develop vesicovaginal fistulas from the pooling finding its way into the vagina. The ureter, similar story, urinary ascites, ureterovaginal fistulas, and you'll see on scans that they'll have hydroureteronephrosis. So how the heck can we prevent these things? What's the role of preoperative stent placement? They are good for the higher risk cases. They don't actually reduce the incidence of ureteral injuries, but they do help with the intraop recognition of injuries. You can do a variety of types. A lot of people like these lighted fiber optic stents for MIS procedures, but they're not risk-free and they're not perfect for every case because you can cause anuria, no urine, in 1 to 5% of the cases, likely due to inflammation, but they can be quite distressing when you're worried about a ureteral injury and not having any urine from the Foley catheter. And we injure the ureter, like I mentioned earlier, more than anybody else. So this can happen 1% of the time. And sometimes we're not able to put them up in one side or both sides for a minority of cases. Okay, thank you guys for the opportunity, and I'll be available for questions after this presentation.
Thank you so much, Paul. Yes, please.
Hi, Paul. Thank you so much for this excellent talk. And I'm Arthur Hsu from National Taiwan University Hospital. And I don't know if you noticed, but the field of GYN oncology is having a de-escalation in surgery, and like few radical hysterectomies are done right now. And so like people, like students don't even know like what's water under the bridge other than the atlas. And in this circumstances, like, do you see, like, more? You said that the percentage of collective system injuries are about 1%. Do you see that in the United States, the rates are higher, are getting higher, or actually getting lower? And if it's getting higher, what's your suggestions for the residency program as a urologist to join the field of GYN? Thank you.
Great, thank you. Thank you for such an important question. It's experience. We see experience really help reduce injuries, and inexperience really increase injuries, almost tenfold in the inexperienced surgeon. And that depends a little bit on the surgical approach. You know, MIS is more commonly done, and MIS surgery results in a lot of injuries when they're not familiar with the anatomy or unfamiliar with the setup. So I think it all comes down to what you alluded to, which is people need experience. They need to be able to be comfortable doing these operations to be able to do them safely.
Any question from the floor? I believe ureteral or bladder injury not occur in the young doctors, also to the experienced doctors. It should be very careful to do this operation. Any question or comment from the floor? Paul, I've got a question for you. For this, for the urine injury, it's more common in the inexperienced young doctors. will you please talk more how to prevent from injury? I believe that's important because prevention is better than treatment, right?
Right, exactly. And I think, using ureteral catheters can be helpful for at least identifying it, because it's one thing to injure the ureter. It's obviously worse if you identify it or fail to identify it after and have the sequelae and the grief that can happen to patients. So using ureteral catheters when you're uncomfortable can be helpful. And then, whenever you're worried about a structure, going and finding it, identifying it up front, moving it away from your surgical field can be helpful for reducing injuries.
Steve, do you have any comment or question for Paul?
Yeah, I do. Thanks for the talk. One of the things that I have found over the years, which makes me laugh, is when we run into a bladder injury, whether it's vag his or abdominal his or even at a complicated C-section, our younger people seem to immediately say page urology. And I'm always like, just get me some suture and we'll just fix the bladder. Like, I don't see what the big deal is. And so I guess maybe my question is, what have you seen people do wrong closing bladders that has maybe given people such fear of repairing it?
I think people are fearful from a medical legal standpoint. I think, technically, if you're a good surgeon, you can do a lot more things than you may have confidence for or feel comfortable, under the legal stand, if you will. But I think where I see younger surgeons or maybe inexperienced surgeons fail to make good closures, sometimes it's getting the proper exposure. The bladder's inflamed and stuck all over the uterus. Just taking a few moments to move the bladder away from the uterus so you have a tension-free closure. Or if they have concerns about the ureter and they just are hyper-focused in their field, not taking a second and going away and kind of identifying the anatomy where it's more normal and tracing it back down. So I think it's just, it's easy to call someone in for help, but while you're waiting, sometimes it's nice to set yourself up for how you would fix it and maybe start fixing it yourself and see what the expert says when they get there. Maybe you like your closure better than theirs, or you can pick up a few tricks along the way as we all learn how to do these operations.
Yeah. I think for many of our trainees, at least when I was a resident, we did a lot more open abdominal hysterectomies. And in those open cases, we routinely opened up the sidewall, we tracked the ureter down. Even if we didn't have to do a major dissection, it was a learning experience for us. We were, just opening the area. And I often feel like, our residents are doing much more laparoscopic and robotic surgery and not necessarily as comfortable doing that kind of work.
Yeah, thank you. Any more questions from the floor? Because I have several minutes left. One more question for you. Before repair the fistula, normally we need to wait for some time, maybe 1 week or 0 weeks. Before repair the fistula, we normally to look at the tissue condition. You talk more on this for young doctors. Do you suggest to wait or do it immediately?
Right. And that's actually been something that's been evolving in our field. So sometimes people have an injury and it goes by unrecognized beyond 1 or 2 weeks, and people really worry about going back in the abdomen during that kind of no man's land time, where the worry is that the tissue quality will be poor and you could have bowel injuries from retracting bowel. But there's been some more aggressive urologists lately, particularly in Philadelphia, showing that if you go in whenever you find the injury and fix these problems, that they're actually okay. But that's kind of a controversial thing as far as the optimal timing for this. Certainly someone who has ongoing infection or metabolic derangements, better to medically optimize them before you go in and try to do a reconstructive procedure. Draining the abscess, putting them on antibiotics, correcting the acidosis for those who have urinary ascites. Those are good steps to do. But as far as how hostile admin will be or won't be. That's something I think people are lessening hard rules for, wait 3 months, etc.
How long to wait is always not fixed things. It's controversial, depends on the tissue's condition. Finally, I've got a sensitive question for you. Once have the urinary injury, say blood injury or urethral injury, do you suggest gynecologist to repeat his own or refer to urologist? You know, in Taiwan or maybe in States, might have conflict between the interest of gynecologist and urologist. How do you think?
Yeah, I think it all goes back to that experience point we made earlier. I've worked with gynecology oncologists who felt very comfortable repairing the ureter if it was injured distally or the bladder in minor cases. So I think if you feel comfortable that you can do an adequate repair and the patient's going to do well, consulting urology may be more for your own medical legal coverage. But I think it all comes back to your comfort levels and what you think you're going to do best for the patient.
Thank you. Steve, do you have any comment on this session? Steve,
on repairing yourself or any other questions? No, I think, look, I mean, I think we all see urologic injuries. If we're doing enough cases, we're going to see these things. I definitely think our residents probably need a little more time with urologists to see some of these things happening outside of a situation where it's an emergency or where you're running into a complication at the time of surgery. I think many of our residents don't get much experience with urology or urologic procedures as maybe they should. And we certainly call in urology a little too quickly, I think, for many of these cases that we should be repairing ourselves.
Okay, thank you. Time is running up. Allow me to move on to the next session. Thank you so much for Paul and Steve. Thank you so much. We'll give a big hand to both of them.
Thank you. Thank you very much.
Thanks, Paul. Nice meeting you.
Bye. Thank you.
Now we hold this section. This section is my honor to co-chairman with Professor Yang. Professor is the chairman in the Department of OBGYN, National University Hospital. And I am from the Changshan, professor in the Changshan Medical University. Now this section, I think that the speaker is the Professor Kang, is from the National University Hospital. I think that the Professor Yang to introduce the Professor Chang, please.
Thank you. It's my great honor to co-chair with Professor Lee. And Professor Mei-Zhou Chen, she is now the professor of Department of OBGY, National Taiwan University. And she is also the director of Division of Reproductive Endocrinology and Infertility in NTU Hospital. She was the past president of Taiwan Society of Reproductive Medicine. And she is now the committee member of REI in Aspire. So Professor Chen will give us a talk about microbiome. Let's welcome Professor Chen.
Thanks, Professor's kind introduction. And it's truly my great honor and pleasure to join and to participate in the AT Joint Conference. And for the presentation, I would like to express my gratitude to the organizing committee for inviting me to be here. And my topic to present today is regarding the microbiome and whether it's meaningful to the fertility. And I'm Dr. Major Chen from National Taiwan University Hospital. And this is a COI disclosure slide. And before the presentation, I would like to disclose that whole patterns of probiotics that is capable to metabolize sex hormones. And one of them has been licensed through the technology transfer agreement. But I won't present this research work today. And in addition, I have to declare that I have received an honorarium for the presentation from TAOG. And otherwise, I have no other conflict of interest to disclose. As we all know that reproductive choice is not sterile at all, and the success of IVF, the factors that contribute to a successful IVF treatment is not only include the embryo quality and good endometrium for implantation, but now the microbiome has also considered to play a very important role. And the reproductive tract contains many kinds of microbes, including bacteria, fungi, and various kinds of viruses. Microbiome of the human is changed, it's different across different stages throughout a women's reproductive life cycle. And it's largely affected by the changes of sex hormone. There are 3 stages for a woman: menstrual cycle, pregnancy, and menopausal transitional stage. As shown in this figure and in this slide, it's already known that for women at the menstrual cycle, the microbiome diversity is higher in the early follicular phase compared to the luteal phase. And at the early stage of pregnancy, the microbiome diversity is higher and will become more homogeneous when it goes into the middle and late stage of pregnancy. And during the menopausal transitional stage, as Dr. Huang mentioned earlier, that the microbiome diversity are increased after the menopause. All of these will result from the changes of the sex hormone, including the estrogen, progesterone, and testosterone. Estrogen, probably the most commonly studied sex hormone to study its association with the microbiome. As Dr. Huang mentioned earlier, that estrogen can change the vaginal environment through stimulate the vaginal glycogen production, and the abundance of the glycogen can promote the lactobacillus dominant in the microbiome profile in the vagina. And in addition to change the environment, estrogen can also be regulated by the gut microbes directly. And certain gut microbes can secrete the enzyme called beta-glucuronidase. It's an enzyme that can deconjugate the estrogen, so make the free estrogen be able to reabsorb back to the circulation, and that further increase the circulating estrogen level. So for these reasons, there are increasing studies to link the microbiome composition to many kinds of estrogen responsive gynecological disease like endometriosis and myoma. And as shown in this slide, that increasing firmicutes large spectral ratio will increase the free circulating estrogen through the beta-glucuronidase secretion from the microbes. And so because if the microbes can secrete, if the microbes in the not able to secrete enough beta-glucuronidase, then most of the estrogen will be excreted in the feces in the conjugated form. So that's the link. That's one of the one of the reasons to link the microbiome and the benign gynecological disease. And besides estrogen, other sex hormone can also be regulated by the gut microbes. This study is from our research team. We has found a specific gut microbe it's able to metabolize androgen directly. And so if we fed mice with these microbes, then we found the circulating testosterone level will decrease. So it's further, so that's the first time we prove that not only the microbes not only to regulate or regulate the sex hormone through indirectly. It is the first time to prove that it can directly to metabolize the androgen into the inactive metabolites, so that further decrease the circulating androgen level. And also, progesterone is the same. Our research team has identified gut microbes called Clostridium inoculum. This microbe is a very common pathogen in the human gut. We isolate these gut microbes from an infertile women undergoing sole embryo transfer. And we found women with higher abundance of these gut microbes, their progesterone metabolic activity are higher in their feces. So that means they may have lower circulating progesterone level with the same amount of progesterone supplementation. And further, when in the animal study, we found when we fed mice with these kinds of progesterone, with these kinds of gut microbes, it's not the mice will not only the progesterone level will decrease, but also it will affect the animal's estrous cyclicity. So that's the evidence to link the gut microbes to the progesterone insufficiency and the chronic anovulation. And just 1 year later, not 1 year, several months after we published our study, we found another very interesting report published in Cell Host and Microbes. It's in this study from China, they recruit 5,300 pregnant women, and they also found the same. They also have the similar finding. They identified that if the pregnant women they have the higher abundance of Clostridium inoculum, the microbes we mentioned earlier, then they have higher risk of preterm birth. So it's also an evidence to link the gut microbes is associated with poor reproductive outcome. Okay, besides regulating the sex hormone, conventionally, traditionally, we think the microbes can affect the health is through regulating the host immunity. So it can exert both the pro-inflammatory and anti-inflammatory effect on host. And for the pathogenic microbiota, it can exert its effect through excretion, lipopolysaccharides, flagellin, beta-glucuronidase, bile acid, or peptidoglycan to activate the immune reaction. But on the other hand, for the healthier microbes, it can act as an anti-inflammatory agent through excreting the microbiome metabolite like short-chain fatty acid, bacteriocin, gut hormone, etc. So it's already known that chronic low-grade inflammation is highly associated with the occurrence of female infertility. So any sources that can contribute to the chronic low-grade inflammation, including the genetic background or epigenetic regulation from the environment as pollutant or the sedentary lifestyle, poor diet habits as well as gut dysbiosis that can contribute to the chronic low-grade inflammation. And all of these has been reported to associate with several diseases that related to the female infertility, like the obesity, chronic endometritis, adenomyosis, endometriosis, POF, and ovarian. Now it's polyendocrine metabolic ovarian syndrome, as well as autoimmune disorders. So providing personalized nutrition has been considered as one of the strategies to manage the female infertility based on the dealing the chronic low-grade inflammation perspective. So there are four domains that we can put effort in. One is nutrigenetics, nutrigenomics, metabolomics, and microbiomics. So targeting microbiomics can also be considered as a strategy to treat female infertility. But reproductive tract microbiome is not like what we understand about the gut microbiome. In gut microbiome, most of the data shown that the higher the diversity, the healthier the human, because the higher the bacterial gut microbiome diversity, usually linked to the lower risk of metabolic disturbances. But it is opposite for the reproductive tract microbiome. The reproductive tract microbiome was considered to be linked to the poor reproductive outcome if it has higher microbiome diversity, especially with lactobacillus depletion status. So that means with more homogeneous microbiome diversity, with lactobacillus dominance, is beneficial for a favorable reproductive outcome. And many factors that can contribute to the reproductive tract microbiome environment, including the baseline ethnicity, genetic background, whether the women get pregnant or not, the sex hormone status, as well as the exogenous chemical or the sexual activity, or even the administration of probiotics or antibiotics. All of these could contribute or result or will affect the reproductive tract microbiome composition and their diversity. And then I will show you some clinical evidence to prove the impact of microbiome infertility. It's a prospective cohort study that they recruit about 450 subjects who plan to undergoing sole embryo transfer with hormone replacement for endometrium preparation. All the recruited participants were received endometrium polyp collection as well as endometrium biopsy to check for the microbiome profile. But for this study, actually is an observational study, so there is no action text, even though they have identified the bacteria. But the outcome were measured for each participant, and they were divided into 5 groups, including live birth group, biochemical pregnancy group, clinical miscarriage, ectopic pregnancy, and also the patient with eventually did not get pregnant were also collected for the analysis. And the results shown that for women who eventually get the clinical miscarriage, had the highest proportion of detectable abnormal vaginal microbiome profile. And the group without successful pregnancy ranked the second. For the patient who eventually got a live birth, have the lowest proportion of detectable abnormal vaginal profile. And these 2 specimens the author found that the endometrial fluid is easier than the endometrial biopsy to identify the abnormal vaginal microbiome profile. And the dysbiotic endometrial microbiota profile are different between these two, from the specimen from these two origins. But most of them, but some pathogens are still in common, and these common pathogens are highly correlated to what we see in patients with bacterioid vaginitis. And the one thing in common and the most important to highlight is the lactobacillus is always dominant in patients with live birth outcomes. Like women, male's fertility is also considered to be affected by the microbiome profile. And this is a study that will treat the young mice with the old mice feces and found the semen quality getting poor for the young mice. But in contrast, on the contrary, if they fecal transplant the young mice feces back to the old male mice, then they found the semen quality of the old mice get better. And the researcher dived into the potential mechanism and found that through the metabolites excreted by the gut microbes that further affect the spermatogenesis. And here is a review article just published 2 months ago in Fertility Severity that researchers compile lots of up-to-date evidence related to the fertility microbiome and male fertility. And like what we see in women about the gut ovarian axis, there is also a gut testis axis in men. And the microbes can exert its effect to affect the semen quality through excretion, the metabolites, hormone, cytokines, and to disrupt the barrier and mucosa of the testes that further affect the semen quality. But since microbiome is not seems to have a very important role in affecting the reproductive outcome, whether or not if we administer the antibiotics or the probiotics in advance for women with adverse vaginal microbiome profile help. And here is the randomized double-blind placebo-controlled multi-center trial. It is the largest study now for this kind to investigate the effect. And this study recruited more than 1,500 patients to check whether they have abnormal vaginal microbiota profile. And if they have, then they will be randomized into 3 groups. One group received antibiotics plus vaginal probiotic treatment. The second group only received oral antibiotics treatment. The third group received only placebo without active treatment. And the result is far from our expectation. Although the 2 groups who received antibiotics treatment, the vaginal microbiome, the bacterial eradication rate are very high in these 2 groups. But when it comes to the pregnancy outcome, both ongoing pregnancy rate and live birth rate show no significant difference among 3 groups. Further, the adverse events reported related to the antibiotics use are significantly higher compared to the group without antibiotics use. And as for the vaginal probiotics patients, and many women complained of vaginal itching. So according to the result, since the treatment does not seem to improve IVF outcome, So the researcher conclude that routine screening for abnormal vaginal microbiota prior to IVF is not recommended. But if that means checking microbiome really means nothing to fertility, in the same study, the researchers further analyzed their data and found that if the women they have spontaneous lactobacillus dominant in their vagina, then it's still benefit for the it's a benefit for reproductive outcome. They have higher clinical pregnancy rate. But if the lactobacillus dominant in the vagina is induced by the probiotics, not spontaneous occurred, then it has no effect on the pregnancy outcome. And last, I will show you two studies using probiotics in IVF treatment. And one is the probiotics given through vagina 10 days before the embryo transfer. The other is to give oral probiotics for both partners, both husband and wife, and they observe the live birth rate. And the design are quite different for these two studies. So actually, I shouldn't compare them together, but I want to show you these two randomized control trials. Okay, and the first study, they use the vaginal probiotics, and they found at the beginning the study aim is to investigate whether the microbiome could be eradicated through given the vaginal probiotics. But the result showed the result is not as expected. It doesn't show significant improvement with the vaginal probiotics treatment. And even the spontaneous pregnancy rate seems to be lower in the treatment group. And as for the another study, they use oral form probiotics treatment for both husband and wife. They also found there is no significant difference of the microbiome profile for these two groups after the probiotics changes, but the live birth rate was significantly higher for the treatment group. And the potential reason that contribute this is that might be the environment for the immune function was improved, and so that makes the wife and the husband's semen quality may improve, and the wife's environment for the implantation was improved through the probiotic treatment. So that makes the result. But actually, that kind of design is still not able to answer whether the oral probiotics is really beneficial for the vagina, for the reproductive outcome, and through the reproductive tract microbiome modulation. So we still need a larger, well-designed study to answer this question. And I found there is a protocol published last year in BMJ Open that it will be a randomized placebo-controlled double-blind trial. And let's wait and see the results. In summary, and I would like to, in summary, my presentation today is the success of fertility treatment. It depends not only the embryo quality, endometrial receptivity, but also on the reproductive tract microbiome. And the microbiome can influence and being influenced by reproductive hormones. Dysbiosis of the reproductive tract is associated with a higher miscarriage rate and lower pregnancy rate in women undergoing IVF treatment, as well as impaired sperm function in men. And currently, the evidence not support the benefit of vaginal probiotics or antibiotics to improve pregnancy outcome. But oral probiotics seems to have some potential to be beneficial to the reproductive outcome, but more evidence are still needed. Thank you very much for your attention.
Thank you, Professor Chen. A nice talk. And I have a question about because the microbiota had a different method to detect it, including the R0SP and depend on the SMP method. What kinds of method is the better for the detecting the microbiota? Now we have two kinds of methods to do right now.
Actually, there are at least 3 or 4 kinds of methods to measure the microbiome profile. And most of the, probably we can say the oldest one. The oldest one is to do the 16S RNA sequencing. But right now, it depends on what kinds of micro you want to detect. And for the things usually in our setting, we not expected to do the exploratory microbiome examination because it's not in the research field. It's just for the clinical use. If it is just for clinical use, then the traditional 16S RNA sequencing or the some we can adopt the NGS is also fine, or use the array is also fine. If we choose the array, that means we have some plan to check some genus or some species we plan to check in this platform. Yeah, so that we have to, but there are only limited strains that we are able to check. Yeah.
Okay. Because you take a sample in the operation room is because the environment can affect it to the microbiota distribution. How do you avoid the environment to contamination for the microbiota?
So it actually is not able to avoid the contamination from the environment. It's impossible. Yeah. So for example, like our research team, we do the culture method. Yeah, we do culture. We do culture. We do the culture. Probably in very old fashion. We for the examination for the bacterial culture, we do the broth. Yeah. So that we set up the condition, and so that we are able to identify the microbes we want to see in that kind of circumstances. But if we want to screen the patient, then we have to do the PCR. Yeah. And for example, if I show you some specific bacteria that are able to have some certain function, and if we want to check that kind of bacteria, we can use their the specific gene that are specific encode that kind of bacteria. That will make the examination faster. Yeah, so that's a fast screen, fast track screen. I don't know how to say that, but it will shorten the examination time. But if we want to screen the whole microbiome profile, then we can do the whole genome sequencing, to the whole bacterial genome sequencing, or to see the microbiome. Yeah, but in that will be the issue. The problem will be you won't know what bacteria, what microbes is specific to the condition you want to see. You can just see the composition and the diversity. Yeah.
Professor Yang, how about your idea?
Is there any question from the audience?
Professor Chen, thank you so much for your excellent talk. I just have one question about a randomized control trial on Nature Communications. And since there were patients that had spontaneous lactobacillus dominance, why were they included in the trial in the first place? I mean, I thought that you wanted to, the researchers wanted to boost the microbiome by a supplement. And,
why they already have lactobacillus dominance, but they still recruited for randomization? Yes. Is that correct? Okay, it's come back to the, should go back to the design of the study because they only recruit subjects with identified abnormal vaginal microbiome. So that doesn't mean they are not lactobacillus but dominant. But they also have the abnormal vaginal microbiome profile.
Is there any other question? And since time is limited, and thank you, Professor Chen, for your excellent speech. We will close this section. Thank you.
Thank you so much.
Thank you for all the attendees, speakers, moderators, and the organizers, especially Professor Marco Francesco. As we know, he got atrial fibrillation recently after a severe URI infection, which complicates the disease. He feels fatigue frequently, but she still pay a lot of attention to organize all the conference. Of course, we would like to also thank the Jenny, Haywood, Tate, Steve, May, and Christine, the two Taiwan daughters, Irene and Paul, and of course, Paul's father, Tom. And so many friends from ECOG. For example, Camille, Stella, and Berta, etc. So in my point of view, the American-Taiwan Joint Conference is not just an academic conference. It's also a chance for family union between ACOG and the TLG. So if TLG have some achievement internationally, it is not only because our own effort, but also from the help and the care from our friends and family. We can thank enough to express our most sincere gratitude to the friends and the family in ACOG. But we would like to say again, thank you so much to our ACOG family and the friends. And now is the time to say goodbye. We need lunch and then they need sleep. So hope you all have fun and take a rest. So see you next year, and if possible, every year. Okay? Thank you.